that's what you're seeing in this image here. There's mucus. There's some mucus secreting glands and also some dribbling down from the bronchi. Now, what's the significance, the functional significance of this airway that has smooth muscle but no cartilage? Pardon? Exactly. It can constrict and decrease the diameter of the airway, or dilate and increase the diameter of the airway much more significantly than any other more proximal structures. When we leave the bronchial, our next airway is an alveolar duct that doesn't have smooth muscle. So without muscle, it's not going to be able to constrict at all. So this is, it rhymes with arterial, which was one of our blood vessels. And what was the significance of the arterial?
It was the site of blood pressure regulation?
Exactly. The arterial had enough numbers of vessels that it became very significant in surface area. It had smooth muscle, unlike our capillaries and venules, post-capillary venules anyway, that it could constrict and dilate. And so that was the site of blood pressure regulation in the sympathetic nervous system. The bronchial is the site of airway flow regulation. Right? So someone who has asthma, and there's two things that are involved. There's a constriction of the bronchioles, but there's also an increase in fluid and mucus secretion. So the airways are decreased for two reasons. The surface covering, the fluid and mucus covering the surface, as well as complicated by the just overall decrease in diameter. Now remember, under respiratory zone, we started our respiratory zone with a bronchial. Not just a plain bronchial, but what is known as a respiratory bronchial. Let's see if I can copy this slide and increase it. Make it a little bit larger here. So all of this is bronchial. What you're seeing here is simple cuboidal epithelia. No cartilage. This is a blood vessel. You're seeing blood cells inside the blood vessel. If you were on the microscope, how could you tell the difference between a bronchial and a blood vessel? Because they both have smooth muscle walls.
The simple cuboidal?
The epithelium. Because a blood vessel is going to have simple squamous, and the airway is going to have simple cuboidal. So a thicker epithelium. So now we have a branch of our bronchial, and notice what happens here. We're giving off here's another piece of bronchiolar wall, and yet we have these little blebs like grapes of alveoli, and the structure of an alveolus, it has an epithelium of simple squamous. So as soon as we get this simple squamous epithelium, we can have gas exchange, because it's thin enough for gas exchange. So that's why this is called a respiratory bronchial. It's alternating smooth muscle and simple cuboidal epithelia with airways that can do gas exchange. So that's a respiratory bronchial. As soon as we see a respiratory bronchial, that region proximal to it is known as a terminal bronchial. If all you saw was this, or if I go back to the previous slide, if all you saw was this, you would not be able to know that that was a terminal bronchial. You have to know that there's a respiratory bronchial to identify a terminal. Right? So if that's all you see, just bronchial is what you would identify it as. So it's usually easier to find the terminal bronchioles. You have to have a longitudinal component to do that. So you would have something like this with simple cuboidal epithelia. And then you would have a segment where you would have an alveolus of simple squamous, and then you would have simple cuboidal again. Now this is a longitudinal section, so remember our smooth muscle is going to be cut in cross section, like our blood vessels, because it's going in a ring. So this is going to be an alveolus. And so at this point, if this is the first one we can find, that would make this the terminal bronchial, and this the respiratory bronchial. Okay? So again, they're a lot easier to identify on a longitudinal section. On a cross section like this one, I wouldn't have put the terminal bronchial up there because it's part of the respiratory component. See if I have other slides. All right, so here, the X would be respiratory bronchial, okay? Because here's an alveolar sac or alveolus here. Here you can see the thicker wall with the smooth muscle and simple cuboidal epithelia. Right? So most people understand the respiratory bronchial concept. The next one is a little bit more difficult, and that's the concept of the alveolar duct. We lose, with our alveolar duct, we lose smooth muscle. Now you might be able to see little knobs of smooth muscle, all right? But for all intents and purposes, we don't have it. So if it's a test question, the answer would be no, even though you might find tiny little islands of it. So there is no, or negligible, no cartilage, obviously. And our epithelium is simple squamous. So essentially what we have is a large hallway with alveolar sacs that are widened, kind of opening up into it. So this whole structure here would be the alveolar duct. So again, where these arrows are, so it'd be like a hallway this wide, and then wide doorways, all right, that have some alveoli opening off into them. So rather than a narrow doorway, it would be like a wide arch. You're walking down the hallway and you can see into smaller rooms. And that very wide hallway would be the alveolar duct. From one alveolus to the next, we have small openings known as pores. So that would allow us to go into this alveolus. That would have a small pore that would allow us to go into that one. And that would have a small pore that would allow us to go into that one. All right? So we don't have these wide spaces. That's the alveolar duct. And then we would have an individual alveolus, which has the same characteristics, just has the pore open. All right. So here would be the alveolar duct, and then these small little sacs are the alveoli. So on this image, we would have our respiratory bronchial. Here's an alveolar duct down here. Here's another alveolar duct here. So it's just a wider passageway. So terminal bronchial, respiratory bronchial, alveolar duct, okay, with individual alveoli. Here's another alveolar duct here. So we're just getting into more and more narrow components. Yes?
So these over here with the pores, those are individual alveoli?
Yes.
Yeah.
Or so.
Alveolus is singular, right?
Yes. So a respiratory bronchial is a bronchial that has individual alveoli opening up into it, but the structure of the bronchial is still a simple cuboidal epithelium. An alveolar duct has all simple squamous epithelia. up to this diagram here. So we have patches of cartilage in the bronchus, no cartilage at all in the bronchiole. And when we start seeing little alveoli, little blebs, I think I have a previous picture that's better. Then we're at the respiratory bronchiole. Okay. So again, a classification histology-wise is picking those up. So here's a respiratory bronchiole with simple cuboidal walls that have alveolar sacs. In the alveolar duct, this is all simple squamous still. Not still, but we've changed to simple squamous. That's the key difference between alveolar duct and a respiratory bronchiole. And a whole lot more of the alveolar sacs. Okay, do you want to take a picture? So those are the characteristics that I've written on the board. The easiest ones to see at the histology level are the cartilage and smooth muscle. And you can identify the airway without knowing the epithelium. Because that's sometimes hard to pick up at the level of histology. Okay. So the trachea and primary have only smooth muscle in the back, C-shaped cartilage, and pseudostratified columnar epithelium. The secondary and tertiary bronchi have pieces of cartilage like paving stones, but all the way around. The smooth muscle is all the way around. And we transition to just simple columnar. We get to the bronchiole and we lose all cartilage. If you still see smooth muscle, whether or not you can identify the epithelia, it's going to be a bronchiole. Okay. And then depending on whether you're looking at individual sacs or a channel of sacs, it's going to be an alveolar duct or an alveolus. Okay, may I erase the board? You guys have your... We have a couple of models of this distal region of the lung. I'll get the other one back there. Okay, so in this model, the light blue is the cartilage. So what airway structure would this be? Below that, we lack it.
Bronchial.
Bronchus, because we have cartilage. And we're so close to the area that we don't have cartilage, it wouldn't be a primary bronchus. So it's going to be a tertiary, at least, not a quaternary. Then we get to the airway and we still see smooth muscle, but no cartilage. So all of this would be a bronchiole. All right? Then we get down to here where we have some smooth muscle and some airway, so we'd be moving into the respiratory bronchiole. But that's kind of difficult to tell. There's a couple, a little bit, this right here is respiratory. You can see a little bit of smooth muscle and a couple of alveoli. And then this would be a alveolar duct, right? With individual alveoli. On the back side of the model, it's showing one large alveolus. And that's what we're going to look at next. One large alveolar air sac. Okay?
It's like pink Cocoa Puffs.
So this is the actual site. Remember the term that I used for gas exchange? What do we call that? We had pulmonary ventilation, which was moving the air into and out of the lungs. And then we had gas exchange from air to blood and blood to air. And that is external respiration. Internal is the same thing, but at the tissues. right? So with our air sac, or alveolus, I tried to switch over to alveolus more because air sac is often used as a whole cluster of the alveoli, okay? I never use it in that terminology, but if you get confused by your textbook, that's what it's looking at. And we have simple squamous epithelium. As well as another type of cell. Has a lot of lipid droplets in it. So this epithelium is identified as an alveolar type 1 cell or epithelium, and it's just our standard simple squamous epithelium. All right. This is identified as an alveolar type 2. Also known as a septal cell. The presence of the lipid droplets is significant because this cell secretes an oily material known as surfactant, at least by the time you're born. Its synthesis starts a couple of weeks before you're born. Anybody know what that's for?
Or for when you first cushion.
It affects surface tension. Is it there to increase or decrease surface tension? Decrease. Remember we talked about hydrogen bonds way back in 430? We didn't do much chemistry in our Bio 430 because I assumed you'd had it before you got to Bio 430. But I did talk about hydrogen bonds. And hydrogen bonds are an attraction between the positive charges of one water molecule's hydrogen and the negative charges of another water molecule's oxygen. So we have something like this. And this would be a hydrogen bond. It's one of the weakest bonds. It's what happens if you have a glass of water and you touch your finger to the surface and then slowly raise it. You can actually raise a thin film of that water because of hydrogen bonds between the water molecules on your skin and the water on the surface. Also, if you have a wet glass or a plate, you turn it upside down and place it on a smooth counter. You kind of have to get your fingernails under it or slide it over to the edge to pick it up because of those hydrogen bonds. So when the fetus is developing the lungs, they're filled with fluid, otherwise they would grow solid. And a few weeks before birth, that fluid starts to be reabsorbed. During birth, during the vaginal delivery, further pressure squeezes water out of the lungs. So premature babies, or babies born by C-section, are at more risk of having this fluid in their lungs, which leads to respiratory distress syndrome. When that baby takes a first breath, it has to break all of those hydrogen bonds. In adult lungs, that surface area of an adult lung is about a little more than half a tennis court. So even if you take 20% of that, that's a lot of hydrogen bonds to break. It takes a lot of energy for the infant to expand, to decrease the thoracic pressure, for atmospheric pressure to push in and break those hydrogen bonds. So then they breathe out, and like a plastic baggie that you've rinsed and hung over the sink, those hydrogen bonds would reform. And this amount of work would have to be done every time the infant takes a breath. The purpose of surfactant is it coats the inner lining of the alveoli and inhibits those hydrogen bonds from forming because it's a covalent, a nonpolar covalent fluid. Doesn't have positive and negative charges. So when after that first breaking of all those hydrogen bonds, the next breaths that the baby takes for the rest of its life are much easier. It doesn't have to break those bonds every single time. To help babies that are born early or haven't started producing the surfactant, first they were put in high pressure incubators, so or positive pressure, so that helped to push the air. They wouldn't have to increase the negative pressure in their thoracic cavity quite as much. And now the precursors to the surfactant can be given as an inhaler, or they can actually be given to the fetus before it's born. Okay, so they can either have these fine little droplets that they give the baby right after it's born, or if they just know they can't stop it, they can trigger the production of this a little earlier. All right, then we have a third type of cell, which is the alveolar macrophage. Now, usually our macrophages are in the connective tissue, right? We have a few in the blood, in the spleen, and the liver. And here, they're not quite exposed to the air, they're just under that surfactant, so they don't dry out, but they are mobile, they can move around. And they are known as alveolar macrophages. They can also be absorbed, they can move across the epithelium and enter the blood vessels. Some studies have found that in individuals who have had heart attacks and then had pneumonia were much more likely to suffer valve disorders or second heart attacks if they had pneumonia after their first heart attack. These alveolar macrophages transmit back to the heart tissue in the bloodstream and transported infections back to the heart. So that's the air sac. That's where air is going to be located. Then we have our capillary. And the capillary is usually formed of one or two epithelial cells, simple squamous. Their nuclei are usually situated so that they don't interfere with gas exchange. So they're not going to be on the side closest to the air sac. And so we have a sandwich of two simple squamous epithelia with a very fine, minute amount of connective tissue in between. And this sandwich is identified as a respiratory membrane, not a respiratory epithelium. Remember, that was an alternate name for our pseudostratified columnar. So this sandwich is the simple squamous of the alveoli. Loose irregular connective tissue, a small amount in the basement membranes obviously, and then simple squamous of the capillary. And that's the distance, the thickness of that respiratory membrane is the distance that gas exchange has to occur. So anything that increases that, bless you, like pulmonary fibrosis or pneumonia. So if we have a thickening of the connective tissue in pulmonary fibrosis or increase in fluid in the lung with pulmonary edema or pneumonia, that's going to increase the time it takes for gases to diffuse out of or into. And we'll look at that when we talk about external respiration. So here's just, see these little droplets, these little lipid structures? That's how you know that that's a septal cell or an alveolar type 2. I'm embedded in there. And then this would be just the simple squamous, and this would be a macrophage out, actually on the airway, but.
The lipid droplets,
Those are what are going to be converted to surfactant.
and are those being constant? Is the surfactant being constantly produced in the lungs?
So here's a view of the lipid. Here's the little lipid tails. And then the alveolar macrophage is underneath that, otherwise it would be exposed to the air. So it's deep to that surfactant membrane. So the nucleus at the top would be the nucleus of a simple squamous epithelium, and this cell that's in the red box would be another electron micrograph view of a type 2. And we'll come back and look at these structures when we do physiology. So dust cells is another name for an alveolar macrophage. They uptake fine particles. In someone that has asbestosis or pulmonary anatomy, where they take in asbestos fibers, those or any other type of carbon fibers, those are not broken down. They're not proteins, so they're not broken down by the proteases of the macrophage, and they stay in there forever. All right, the last thing I'm going to finish in about the next 15 minutes here is looking at the lungs. Which are pretty basic. Can I erase the board? Yes. These are pictures. So we'll come back and look at these structures again when we talk on Tuesday, when we talk about external respiration and the factors that affect diffusion. Going back to Bio 430, remember we talked about concentration, diffusion distance. All of those components are going to come into play here. All right, when we look at the lungs, on the right lung, we have 3 lobes separated by a fissure, 2 fissures. And on the left lung, we have 2 lobes, also separated by a fissure. Now there are surfaces to these lobes and regions. So the top, remember some of the terms we had for the parts of the heart? The pointed part is called the apex. In the heart, the apex was at the bottom. That's where the pointed part was. All right, point to yourself where you think the apex of the lungs would lie. There's the collarbone. Where do you think the apex is going to be? Okay? All right, if you take in a deep breath, your apex is actually up here about 1.5 inches above the collarbone. So again, nobody's ever written me back to thank me, but if someone's coming after you with an ice pick and they're going to stab you in the neck, remember when we did the spinal column, I said the best place would be in the neck region because spines are horizontal there, all right? From the back, at the thoracic level, they tend to protect each other by shingles. If they're coming at you from the front, it's a good thing to run away, all right? So as you're running, well, I've also heard it's a good thing to go right up to them because if you're 2 inches from them, they can't get enough leverage. But anyway, you don't have time to think, I would just run. So when you're running away, you don't want to go, ah, you want to go, because as you squeeze that air, notice how I did that off camera? Squeeze that air out. As you squeeze that air out, of course, your lungs are coming deeper down into your thoracic cavity and won't be up in your neck. Because if you get your lungs stabbed in your neck, you're going to get a collapsed lung, in addition to all the other problems. Okay?
Okay.
As far as your adrenal reaction, though, you're going to be breathing more, not less.
If you break your collarbone, though, can that obstruct breathing then?
If you break it at the time you're breathing in, so it's on that deep inspiration that it would rise above.
But my point is, like, let's say you haven't gotten it reset. It's kind of like